Hello, everyone. This is Dr. Mark Plaster, Senior Executive Editor of Emergency Physicians Monthly, and you're listening to EP Talk, the place where emergency physicians, aka ER docs, come to talk about things that are important to us, both professional and personal. And I'm lucky to have my guest here today is Amer Aldeen, and you're the CMO at USACS, right? Is that right?
Yes.
And I was looking at your bio, and I'm pretty impressed, after UVA. And I have to ask you, religious studies at UVA, that you got your undergraduate in religious studies. Tell me about that.
Yeah, I was always interested in history of religion, and I still recall a conversation I had with my dad, and I said, "Hey, Dad, I think I want to do religious history. I want to be a PhD in religious history." And he said, "No, you're not." And I was like, "What? Why not?" And he said, "You know what? You're going to go out and help people, and you're not going to just sit somewhere and read books and write papers that no one's going to read." And so we talked about it a little bit, and I finally said, "Okay, I'll do what you say," and I did, and that's what happened. I still read lots of books and probably wrote a couple papers that people don't read. So.
You know what, though? It probably changed you as a person. I'm always fascinated by people who have kind of a life outside of or preceding their interest in medicine. And I oftentimes think it makes for not just a wider person, but a deeper person, thinking about why we do what we do, as well as, how we do it and how to be technically good at it. I know a guy who majored in violin violin performance, and who is incredibly good at it. Could have gone on as a professional career as a concert violinist, and he's now a neurosurgeon. And I think that absolutely makes sense. He had the detailed and the obsessive compulsiveness to make him, a good violinist was also what made him a really great neurosurgeon. So I like to hear about those things. You went on from UVA to Northwestern and did your emergency medicine training in Northwestern, where you were a principal investigator in some things related to elder care. That's an interest of mine. Tell me what that was about.
Yeah, I was fortunate enough to be part of the JettyWise project. That was the Geriatric Emergency Department Innovations Project. There was a CMMI grant that was led by Mount Sinai in New York and St. Joseph's Regional Medical Center in Paterson, New Jersey, and we were the third site in that. So it really is a matter of just being in the right place at the right time, being available and interested, and the work from the Sinai folks and the St. Joe's folks has always been excellent in the area of geriatric ED care, and we at Northwestern formed a project where we didn't have a separate space for geriatric EDs. We said let's set up education and protocols and processes and try to take care of patients. So that's what we did.
That's fascinating. And then after that, you started teaching police officers and established the resuscitation. Cardiac resuscitation school or a program for the Chicago police. That sounds like a pretty busy kind of situation.
It was neat. I worked with my really good friend and colleague, Dr. George Champus. He's over at Northwestern still, and he does a lot of work with U.S. Soccer, and he's the medical director of the marathon in Chicago, the Chicago Marathon. And he and I just decided to create a series of videos on hands-only CPR, and we started training schools, and pretty soon it just snowballed into this. He had connections with the Chicago Police Department, and we did their online training for it. So really great when you start with something and you seize opportunity and you just go with it, what can happen. I think for me as a junior faculty member at Northwestern, that was really a very important lesson.
Yeah. You must have been quite a junior faculty member at Northwestern, because not only I suppose it's something to win the Junior Faculty Teaching Award, it's another to have it named after you. So I congratulate you for that, and obviously the residents there at Northwestern and probably think a great deal of you.
I got to say, Mark, that if I could think of the single most thing that I've accomplished, the single biggest thing I've accomplished, or the biggest honor to me personally, I think it's probably that.
Yeah. Yeah, being able to translate our knowledge to residents who are hungry and curious and want to take our specialty to another level is truly an honor. And when we do it well, sometimes we do, sometimes we don't. Obviously, you do it very well, but when we do it well, we have left a legacy that is far beyond us for sure. So, but now I understand that you are with USACS, and I know those guys, but have known them for quite a while. I trained in Ohio and know most of the principals. I have for many years, and when it was EMP, and I was really impressed with what they were doing professionally, and they've only taken that to greater heights. And now you're their CMO, is that right?
Yes, correct.
And tell me, we're actually going to be talking about all things coronavirus. I mean, can we get away? Can we get away from coronavirus? No, we can't. The whole reason. Let me just start this off with the whole reason why I'm even available today. Normally, I would be working today. I see. I treated a case. Oh, gee, last week, and a guy came in from Mardi Gras. It was well, it was early enough in the curve that not many cases had occurred in Maryland, and he came in from Mardi Gras, had a high fever, had a cough, a little short of breath, pulse ox 94, worrisome in a young guy. Got a chest X-ray, ground glass kind of appearance, and I didn't feel that this was something that initially needed to be, I didn't know what the curve was on him. Was he going to be stable, or was he going to tank? I personally didn't have enough information about it, enough experience with COVID-19 to really feel comfortable just saying go home and quarantine. Call me back when you can't breathe. And so I called up the referral hospital, and they heard the story, said sure, be glad to admit him, and we'll watch him, put him on isolation and all that sort of thing. And then we started the steps to try to test him. Well, they wouldn't test him because he didn't have that one criterion was coming from a known source of disease, of people having it. And I argued with the folks at Public Health. I said, it's Mardi Gras. He came from Mardi Gras. There are thousands of people there from all over the country and the world and everywhere else, and they're all rubbing whatever they can rub against each other. And you're telling me that this guy can't come home with a disease of unknown origin? Please. And they wouldn't test him. And so I was sort of left out in the cold to know what, and I kept following him, and he did okay. And then I developed cough. And not much, not wild. I mean, not terribly short of breath. I'm 68. I can have a cough every now and then. I can have a runny nose. I can have some muscle aches. I can have, not feel so great. But I happen to have a 93-year-old mother-in-law who lives in our house. And so my wife is freaked out, and she's saying, you got to find out whether, you pick this up or not. Otherwise, she's already meeting me at the front door telling me to strip naked before I can come in, which is actually a positive thing. I like that. Okay. I'm not complaining about that, but anyway, the idea of not being able to eat dinner with everybody else, treating me like a pariah, is no fun, and if there's no endpoint to it. So finally, yesterday, I came in. There's nobody. I did a 7-3 shift. Came in, nobody in the ER, and I thought, come on, just for and now we've got an outside source doing our coronavirus screening, and so I thought I'll just test myself, see what I get, So I did the swab, sent it off, signed myself in, signed myself out, no problem, harm, no foul, and I'm wearing an N95 mask and a full PPE, the whole 9 yards. I'm doing, I'm completely covered. 15 minutes after that thing goes into the test, my director calls up and says, I heard you're sick. And I said, I'm not sick. I just tested myself. He said, are you sure? I said, I'm not sick. Okay. I'm okay. I just had an exposure. We don't know what the other guy did and how he did. And so he said, now, okay, but you got to tell me, and I got off the phone call, thought everything was fine. 30 minutes later, in he walks. I said, what are you doing here? He said, you're going home. I said, wait a second, come on, I'm not sick. Okay. He said, you're sick enough to get a test, right? Well, yes. Okay. But I'm, anyway, he said, you're out of here. You're out of here until we get a clear test. You can't work. And, uh, and
I
it's,
think you did exactly the right thing.
well, of course he did the right thing, but that it's hard because I was all geared. My schedule was around this. Because I do the other things. I'm a per diem. So he just plucked about $1,000 out of my pocket, to say go home and sit on your porch. And so anyway, that's why we were able to move this up to today. I should be in the ER right now. And do I look sick? No, I do not look sick. Okay, I'm 68. If I had coronavirus, I should be like laying down on ECMO, but I'm not. So anyway, so we're talking about COVID-19 priorities, and I thought it was interesting when I asked you what you want to talk about. The first thing I got was PPE, 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 and I'll throw it to you and tell me what's going on. What are you thinking when you write that?
Yeah, so we've seen everything about COVID-19 in the news. Everything's there. Yes, it's growing. Yes, the cases are coming in. Seattle has been hit. Oregon may be next. California may be next. New York may be next. There's lots of hot spots. Definitely we're going to see these cases. Yes, it's concerning, but there is capacity to take care of these patients if hospitals do the right things, if the general public social distances, everything. It's all good. The one area that
Yeah,
this whole system falls apart is if the healthcare workers do not have PPE. If
right.
we don't have anything to protect ourselves, we're not going to be able to take care of these patients. So, and that to me is the most serious element, because you lose the frontline workforce in the emergency departments and the hospital floors and the ICUs. You lose our physicians, our PAs, our NPs' ability to care for folks. We're in big trouble.
Or if we become vectors.
Or that, yeah,
Yeah,
and that.
if we're picking it up and we're taking it someplace else. I did see a little bit of an insight into this, and being a doctor lawyer, I see both sides of this question. But I was watching a news conference the other day, and they were talking about the N95 masks and how 3M normally produces about 5,000 per month, which are quote medical grade N95 masks. Okay, 5,000. Okay, um, but there's no difference between the medical grade and the ones that the guys use that are out there on the construction sites. For some, I'm not sure what they're manufactured exactly the same. And by simply flipping a legal switch, they removed the 3M's liability in this. 3M went from 5,000 per month to 20 million per month, some ridiculous number of being able to manufacture N95 masks. And it was all because of the bureaucratic liability of putting that many out. And so I wonder how many other things are like that as far as in the supply chain. They're being choked because of a company's liability. I don't know. Do you know of others that are like that? Are we able to make more of the gowns and the gloves and everything else if they opened up the liability issues?
I don't know the answer to that. I would hope yes, and I think you said it's a ridiculous flip of the switch. I say we make it more ridiculous. Let's increase that as much as possible, because this is the one limiting reagent to all of this. And if we lose the game, if we lose time and we lose the game on this, we will see more deaths. I think
Yeah,
that is clear to me.
yeah, yeah. When it's great to have 6 foot social distance. A friend of mine went to uh, went to Home Depot the other day, and he actually took his tape measure with him, and he pushed it out to 6 feet, and he walked around with this 6 foot, just as a gag. He walked around, making sure everybody stayed 6 feet away from him. But you come to the ER, and I put my face right in their face when I'm looking at their eyes and their nose and their throat, and I'm listening. I've got my face down on the right in front of their face when I'm listening to their hearts. How long is the stethoscope? And then I turn around and wash my hands. Okay, I'm good. My hands are perfectly clean. But if you've watched this video, I've hit my face probably 4 or 5 times already. My nose itches, this. So if my hands are clean, they're only clean for about 30 seconds. And then after that, I'd be
Yeah,
washing my hands, all day, every day if I
it's
didn't put on.
virtually impossible to not touch your face, especially when you say, hey, don't touch your face. People are going to touch their face. That's just how it is. I think that recommendation is almost impossible to follow. There are techniques, though. If you're going to examine someone's heart, do it from behind. Put that stethoscope, stand behind them, put that stethoscope around, those kinds of basic things, not to be in
Yeah.
the direct path of the mucous membranes.
Yeah. Well, I mean, how do you look in their throat?
Yeah, no, that's true. Yeah, I mean, these are very hard things, especially without PPE. With PPE, it's not
Yeah.
as big of a deal. Without PPE, it is. The other way to look at their throat is you could, I guess, put up an iPhone with a camera and try to look at the camera, sort of, put the iPhone in front of their face and then look at the camera there. That would be one way to do it.
Yeah. Yeah. Well, there's certainly a lot of different things that we can do, which brings up actually one of the things when you're talking about elder care. Recently, I did a podcast with a gentleman who started a company that did a lot of elder care on-site elder care. They would send a paramedic there using telemedicine and having an emergency physician in one location, having paramedics at half a dozen different locations, and having them feed information. One of the things that's happening with the whole coronavirus shutdown is that I think that we're starting to rethink how many things we can do by telemedicine. And I was just talking to a startup health representative who happens to be my son, formerly the managing editor of EPM Monthly, and we were talking about this idea. He said that emergency medicine is one of those areas that is unlikely to be really affected by the quarantining and the emphasis on social distancing. And I said, absolutely not. Absolutely not, because we all know that a good portion of what we see in the emergency department actually could be pre-screened by using telemedicine, could be put into lower impact, lower distance kinds of things. Your comment about what made me think about that was your comment about the using the iPhone. If the iPhone can do it right here, the iPhone could do it at home. And that's true of so many things now that we should start thinking, using the lessons learned here, and start thinking about maybe doing more and more of this as telemedicine, certainly teletriage.
Yeah, in fact, it brings to mind a couple of points. Number one, the HHS recently relaxed HIPAA for things like FaceTime for Apple and the Facebook Messenger chat and Skype and things like that. So, those were not previously HIPAA compliant, and now they're HIPAA waivered. So there won't be any enforcement of actions against clinicians who use those to take care of patients. The second thing you mentioned is really the exact model for ET3, the new program that CMMI has released, Emergency Triage Transport, or the T's in some order. But the point is that you take a paramedic who's very skilled at seeing patients, triaging them. They get called. They take an iPad with them. If they have any questions, they log up the physician who's on remote telemedicine, and they can safely take care of patients at home without transporting them. And so that program just got approved by the federal government, and I think at USACS we have 10 of our partner EMS systems who we're working with in various markets to try to get those programs going. So they're still not quite yet activated, but ongoing efforts to do that right away.
Yeah, one of the things that this particular program brought up, and actually it was on kind of a postmortem of a failed startup, and part of the problem was that we rely fairly heavily on some basic labs, which as a field physician with the Marine Corps, we had eye stats and some things like that you could take with you and do some fairly extensive blood chemistries and blood counts and stuff and such. And so they were doing this in nursing homes. There was only one problem. There was no way to bill for that. and they were giving that service away for 2 or 3 years until they ran out of money. Then they tried to get Congress on board, and Congress saw that was a great idea, but you know how quick Congress acts for the most part, and they couldn't get it done, and things bogged down, and this particular company happened to go under. But the idea of being able to send out a paramedic, just as you've described, with the adequate cameras and ultrasounds. I mean, we've got handheld ultrasound now. We've got packaged labs, that you could take to the patient's home, or actually the best place is these nursing homes. And if you've got somebody in the nursing home who's able to feed information to a board certified emergency physician who's able to take that and make a very reasoned response, oftentimes the patient stays exactly where they were. They found out that they were able to defer 40% of the admission, 40% of the transports. And that, I don't know about you, but that is a tremendous, well, I think they said 40, they calculated that it would save 40 billion with a B, $billion a year if they could do that. Think if emergency medicine transitioned to a model like that, where really the only people we're seeing in the emergency departments are those that have been pre-screened by a board certified physician. And when they come in the door, or I'm not saying that, obviously emergencies are going to roll in without pre-screening, but oftentimes other things wouldn't. A lot of the belly pains and this, that, and the other. And so I think that we're going to see a lot of transition, a lot of innovative thinking that has come out of this pandemic. And not all of it's going to be all that bad. I think it's going to be helpful.
I mean, like with anything, necessity is the mother of invention. So, it was about time that we started these anyways. It's unfortunate that we had to have COVID, or we have to. I'm not using it in the past tense. We have to have COVID to teach us some of these lessons. But hey, let's expand the innovation and let's make it happen.
It's interesting that COVID-19 has to date, and in the final analysis, may not end up having anywhere close to the death rate of influenza or SARS, or some of the others. And yet the way we responded, it kind of finally was the straw that broke the camel's back. Everybody finally, got so frightened of it, and that we finally, had reached a tipping point, and here we are doing things that we could have done, 4 or 5 years ago. Nobody really took it seriously. Now we've had this massive, stock market crash, and people at home and afraid of each other and that sort of thing. And then now finally, it's like we finally got everybody's attention. Okay, now let's figure out ways to do these, provide medical care without demanding that everybody come sit and wait in the ER for 5 hours. So,
yeah, I think telemedicine is leveraging this really well. We've actually recently partnered with Teladoc to offer a wide range of telemedicine services. And I think probably the biggest thing, you're right in some ways that COVID-19 will be lower mortality than SARS and MERS. It almost certainly will be lower than them. I'm not convinced it's going to be lower than influenza, at least a routine influenza. I think it still will be higher than influenza. But there's a couple of bright spots there too. I mean, I don't want to jinx anything, of course, especially in this regard, but the pediatric effect, the effect on kids has been very low. There's been no reported deaths from kids under 10 in the entire world that I'm aware of.
Yeah.
Same thing with pregnant women, no reported deaths in the entire world, including no passage in utero and no detection in breast milk or amniotic fluid. So these are a few bright spots in a very dark picture.
Even though it certainly is under investigation or deserves investigation, I'm actually encouraged by some of the very, very early anecdotal reports of using Plaquenil and azithromycin and medications that are already on the market. I say that with real caution. These medications are not without side effects, and some of them can be pretty severe side effects. But at the same time, we are not without some insight into how to treat it. and some people have reported some pretty amazing results. So I'll be following those studies pretty closely, and that discussion. If you get on the discussion threads talking about using Plaquenil and azithromycin, because there was a study, I forget where now, Stanford, I believe, it came out of Stanford, that was talking about it, and they were able to clear viruses, the viral load in 6 days. That's pretty impressive.
Yeah, there was a French study as well that looked at that, and what they ended up doing was they didn't have the numbers to show
Right.
Their actual effect based on how they had powered the study, but because the effect was so pronounced in the testing group as opposed to the control group, they released the data early, which is probably the right thing to do as researchers. Just get it out early so people are thinking about it.
Yeah.
That was with the hydroxychloroquine and the azithromycin together.
Right. Yeah. Right now, we don't really know what the dosing should be on that. Again, it's not a big enough study to be able to tell, but I'm not actually trying to advocate doing that as much as I'm just simply saying that we're not left wringing our hands on the sidelines. The very fact that Plaquenil and Azith have some benefit, or we think they have some benefit, actually gives us some insight into actually the way the virus is behaving. And I saw one thread of a guy who said that he took Plaquenil for his rheumatoid arthritis, and oddly enough, he said he's been taking it for 15 years, and he said, I've never had the flu, and I've never had a flu shot. I don't get colds, and it was like one guy. I thought, that's interesting, that it has an antiviral effect for you. So I don't know, maybe it does, maybe it doesn't. You want to talk a little bit about ventilators? If there's anything that kind of hangs over everybody's heads, and that is the thought of having thousands or hundreds of thousands of patients who might need ventilators, and if we don't have access to them. You have some insight into that?
Yeah, I think, if all the social distancing fails, if we don't get enough personal protective equipment, we're going to see numbers similar to what Italy has seen, proportionally speaking, at least. And, the ventilator, from the reports in Italy, they've been making some really hard decisions about who gets ventilators and who doesn't. I'm not an ethics expert. I couldn't comment on the right way to do that. But within our group, within USACS, Dr. Arvind Venkat is actually at Allegheny General Hospital, and he is an expert in emergency medicine ethics, and he's working on some of these solutions to find answers to really tough questions. I think the key is you have to talk about it ahead of time so that when the time comes, you're not hastily making decisions. It's morbid, certainly, but preparation is the key.
Yeah. Discussions are, you cannot say that too much. I mentioned that I have a 93-year-old mother-in-law who lives with us. Her husband, my father-in-law, just died this past summer, and she is one of those ladies who's ready to go. She's sitting there, she's not in bad health or anything like that. But when my wife said something about me possibly being infectious, and that's the reason why I had to stay out of her room, I couldn't get close to her and all that kind of stuff. She said, it's okay, he can come down here. I don't want to be put on a ventilator. I don't want to go to the hospital. It was like, okay, come on down and infect me. I'm ready to go. So the very fact that we had that discussion or kind of referenced that discussion tells me that everybody looks at it differently. And if you don't talk about it, you don't know where they are. She said, even if I get sick, do not take me to the hospital. They will quarantine me, and nobody will be able to come there, and I'll die by myself. I don't want to do that. I went, Mom, that really makes a lot of sense. And that's actually what Call 9, this elder program where they had the paramedics talking in nursing homes. One of the things that Call 9 discovered was that when you didn't treat elderly people reflexively, when you actually treated them in their location, many of them, even if they were found to be sick, did not want to be transferred, would prefer to take it to its logical end where they were. And it started a conversation, and it goes back to I'm looping it back here. It starts a conversation about utilization of resources that really needs to occur well in advance. of sickness, and then when in the early stages of sickness, to be able to talk to people and say, what is exactly you're feeling about how this is likely to go, and how do you want to handle this?
Yeah, there's lots of conversations about, really, we're talking about palliative care in many ways, end of life discussions, palliative care, palliation of symptoms,
Mm-hmm.
and palliative care in the ED. I think we need to start talking about this. We also have a few experts at USACS, Dr. Jose Barquin down in Tampa, where I am, and several others who could speak to this really well. But we have to start discussing these things, especially in the face of inadequate personal protective equipment. I think the first, second, third, fourth, 10th steps are the PPE, which is why when I emailed you, I said these are the things that are the
Yeah.
most important, because we have to have these for our clinicians.
And the logical carry on of that discussion is the safety of the folks out there, you and me, but there's a lot of other people in the emergency department, even the people cleaning the rooms for that matter,
Right.
that I know that I've heard, the public is viewing those of us who do this work as the heroes of the hour. Well, that's wonderful, and I'm happy that they appreciate it. But I would also like to live, And so I think that one of the comments that you made in our communication was prioritizing care for the caregivers. Sometimes we are the last ones in the line. It's the patient first, caregivers last. And I know in the Marine Corps, when we had people coming in injured, there was a reverse triage that said if a Marine is able to be patched up and put back in the fight, he's priority one, because he's the one that's going to get out there and save everybody. Okay. And so, and that same psychology carries over to us in the sense that if we're losing caregivers at a higher rate because of our exposure, we're not helping ourselves by prioritizing an individual patient. Don't misunderstand. I'm not trying to say we de-emphasize them, but it's of absolute importance that we emphasize the safety and health of the providers. You agree?
I do. And in fact, I sort of think of this a little bit. If you think of cardiac arrest and doing chest compressions in cardiac arrest, right? You don't want to stop the chest compressions. I view taking care of our care providers, providing PPE, providing the basic supportive care that we need to take care of COVID-19 patients and all our other patients. Let's not ignore them. That's the chest compression part. The testing of the community, to me, that's the pulse check part. That's the part where you're like, all right, every now and then, let's test the community, let's see where the numbers are. But the chest compression part, which you want to keep that fraction high, that's the PPE, and the supportive care, and then look at these therapies like hydroxychloroquine, azithro, or chloroquine like they're using in South Korea, that kind of stuff. So, testing of the general community is important as a pulse check, but I don't think not more than that.
Yeah, the advice that's being given out, which I think is appropriate, is if you're positive, don't go to the ER. Don't
Right.
go there. You go to the ER if you're short of breath, if you're having symptoms that require more than can be rendered in isolation. And I think for the most part, the public is actually getting that.
Yeah.
They're
Yeah,
getting that.
we've seen that our markets, except for certain areas, notably Las Vegas, which is very hard hit right now, our markets are showing a decline in volume because I think people are generally staying away, except when they're very, very ill. So we are seeing that.
Yeah. I saw one. I heard one twist. I was asking the night doc when I was coming in the other day. I said, "How was it?" And he said, "It was very, very slow." And I said, "Are you think people staying away because of COVID-19?" He said, "Well, they don't actually need work excuses anymore." And I thought, "Oh, I never thought about that. Everybody gets to go off, so you don't need to go to the doctor to not go to work." So I don't know. That's kind of a cynical approach to this, but I think it's likely that people are staying away in listening to their public health advice, and also fear of getting sick when they come in.
Right.
I think that's an issue, And I don't think we can say too much about safety for our members. As I told you, I'm here because my group booted me out. I was trying to go in there and tough it out and wear the mask and the PPE and everything, and they said, no, don't do that. Go home and until we find out you're virus free. So, okay, I got it. Okay, I'll come home, do my part, but I don't like it. So, you made the comment of over information and misinformation is dangerous, and EM clinicians need to be the vector of calm. Boy, I couldn't say. Elaborate on that. Tell me more about what made you write that.
Yeah, I think the biggest thing in our group as well, everyone wants to be helpful. Everyone wants to email tons of stuff. There's millions of attachments and this information swirling. Hey, I heard this, I heard that, I heard this. And that drives people bonkers. And I've been using the metaphor of, we talk about social distancing. Let's get some social media distancing too. Let's take some time away from these media outlets, whether social media or TV news media, and use those as snapshots, but not keep them on constantly bombarding us with information. Find someone in your group, in your practice, who can deliver the information on a set cadence that's not too often. Summarize the information. Don't just forward a bunch of stuff, and make it useful for people. I've tried to do that. That's my role. I feel at my group, and I've tried to do that, and I think it's been successful. And so the misinformation, just like we heard about the NSAIDs and how those might be deleterious in COVID-19. Someone had randomly posted that, physician actually, and I think in France had randomly posted that, and then a number of other European phisians, kind of picked up on that person, and it was
viral. Can I say that?
Right, right. And the interesting thing about that is the knowing what I know about geriatric emergency medicine, NSAIDs in general are not great for anyone who's 65 and older. They're going to cause problems with renal insufficiency, CHF, GERD, reflux, ulcers, things like that. So definitely those are not good. And then COVID-19 outcomes aren't great in 65 plus. So one might make the conclusion that they're somehow related. This is unscientific and unproven. I'm not saying it's blatantly false because I don't know yet, but there's no evidence to suggest this, that one is that the NSAIDs that in age and COVID-19 are potentiating each other in some way. So I would say continue to stay away from NSAIDs in older adults as you normally would, as the geriatric ED experts teach us. And then COVID-19 certainly is worse in older adults. We know that. But NSAID should be fine to use in anyone under 65, whether or not you have COVID-19.
And here we are talking about, calming things. I don't know about you, but I get swamped with people wanting the inside scoop about what's going on. And I think that we have to strike a fine balance, because on the one hand, you'll read these heartbreaking stories of young people, collapsing. They end up on ECMO, and they're disasters. And then you look at some of the statistics, and I was looking at kind of the backstory analysis of the, I think it's called the Wuhan Princess or something like that, the initial, cruise ship that kind of looked at this, where 70 patients came out of that. You have to kind of put it in perspective. Here's 3,000 people who shared the same space for a month, and we're now telling them that stainless steel virus lives on stainless steel, and these cruise ships are all stainless steel rails everywhere, so your hands are on these rails constantly. Mm-hmm. So you had these 3,000 people together breathing a closed air system for a month, and you come out with 17%. The real numbers there were not that, be honest with you, not that impressive. And so, but if you say that, it sounds like you're a denier. And then you look at you look at something like Kirkland Nursing Home in Kirkland, Washington, and you say, well, there are 20 people. I think 20 people died at the nursing home. Well, when's the last time you were at a nursing home? These places are filthy, and they're not really maintained. I mean, not every place is. Not every. I'm okay. Other people are going to be watching this, but the truth is that the providers there, if they're not aware of what's going on, are not scrubbing surfaces all the time. Elderly, disoriented, demented patients oftentimes have droplet secretions and whatnot that can't be constantly wiped up. So it would be very easy to see how that a lot of people in a closed environment like a nursing home, assisted living, could all get very sick very fast and do very poorly. And so there's a lot of different reasons how people could do badly,
Hmm.
and yet we're still talking about hundreds of thousands of cases, potentially cases. So we have that responsibility of dealing with the realism of really sick people and dying people. At the same time, when that's all we talk about, it sounds like the sky is falling, and that we're all going to die. And an interesting twist. Do you have how many? Do you have kids?
I do. I have three.
Yeah, and they're how old?
5, 6, 7.
Okay, they're not in this age group. I've got grandchildren in their teens, and I was talking to my granddaughters the other day, and they were asking me, of all things, they asked me, said, "You lived through the Cold War, right?" And I said, "Well, yeah, I was pretty young. That's a long time ago, but I still." She said, "Did you ever have the drills where you were, ducking under your desks and things, for atomic bombs?" And I said, "Well, actually, I did. I thought it was kind of fun." And my wife said, "No, no, I was scared to death of all these things." And then, but my granddaughter said, "Well, we have active shooter drills. We have, we have all kinds of things, climate change warnings. Now we've got the COVID virus warnings." And she said, "My generation is very cynical about us surviving." And I thought, man, we're just taking these kids and telling them, you're going to die. If this doesn't get you, this is going to get you, and if that doesn't get you, this is going to get you for sure. And so I think that one of our responsibilities, I feel, acutely as a grandfather and as a physician, is to remind people that we're going to get through this. Let's stay the course. Don't get particularly paranoid about it. Let's just do what we're supposed to do. And if we do what we're supposed to do, this isn't going to be bad. It's going to be okay.
Yeah, I think the vector of calm piece I put in there is we have to convey a sense of calm urgency. It's sort of a dichotomy there, but it's really important to use both those words. We have to have urgency. We have to do things like social distancing. I believe in these curfews that like California had just implemented. I believe in this. I think it will work to slow the tide. But we have to do it in a way that's calm, reassuring, that gives hope to people, because I think there is hope. And as you said, we will get through this. We're just trying to get through this with as little damage as possible to the general public and to our clinicians who are on the front lines every day.
Yeah, that's what is it? I've always told my residents, don't let them see you sweat. When everything's when you're running a code or you've got a critical situation, I emphasize that nobody talks louder than me because I'm the team leader. Everybody stays calm, and how to be directive and how to stay on the target, keep your mind in the game, and that sort of thing. But you have to instill a sense of calm while at the same time taking every single bit of information seriously and reacting to it. So I couldn't agree with you more. This has been an incredible conversation with you, and thank you so much for sharing your morning. I'm jealous of you being in Florida, although it is a little bit warmer here now in the Mid-Atlantic in Maryland. But thank you all, and for all of our listeners, thank you for joining us today. I hope if you're listening to this that you take this advice that we need to protect ourselves and our colleagues. We are on the front lines. If you get knocked out, I'm a prime example. If you get knocked out, then you're not helping people. And so it's important that we take care of each other. We care for each other's health. Use the techniques that Amer was talking about trying to keep yourself, regardless of you using PPE, if you have abundance of it or if it eventually becomes more abundant, that's great. But in the absence of that or in the paucity of that, be sure that you're protecting yourself, and so that you can actually stay in the fight. And that's America's best hope, and you're on the front lines of that. So congratulations to that, or I won't say congratulations, but thank you for that. Thank you for that, for the work that you do. All of the emergency physicians and nurses and paramedics and PAs and nurse practitioners and people who clean and people who take our scribes and everybody else who's putting themselves in harm's way for the health of the nation. So thank you. I hope you've enjoyed this, and I hope you'll join us again for other podcasts here at EP Talk. It's the place where emergency physicians come to talk about things that are important to us. So I hope you've enjoyed it. Thank you very much.
Thanks, Mark. Thank you very much.